Hello everyone, and thank you for participating in this webinar organized by the British Institute of Radiology on abdominal imaging manifestations of COVID-19. I am Dr. Minal Jaktiani, consultant radiologist from London Northwest Hospitals, and will be moderating this session. Our speakers for today are Dr. Rajesh Bhayana, who is from the University of Toronto, and Dr. Avinash Kambadakone, who joins us from Massachusetts General Hospital in Boston, my second home. Avinash and I go back quite a few years when we both started out as fellows in the Abdominal Division of Imaging at Mass General. I am so happy and proud to introduce him today as Chief of Division. Welcome both Rajesh and Avinash, and thank you for joining us. There are a few points for the delegates to note before we begin. You will see two chat boxes on your screen. Please use the technical chat box for any IT questions only, and the designated Q&A box for questions to be discussed with the speakers in the final 20 minutes of the session. Without further ado, I shall hand the session over to our two esteemed speakers.
So hello everyone. I hope all of you and your loved ones are healthy during this unprecedented crisis. I am Avinash Kambadakone from Mass General Hospital, Boston, and I will be doing this lecture with Rajesh Bhayana, one of our outstanding fellows and now faculty at University of Toronto. Firstly, I want to thank Minal Jaktiani and the entire team at British Institute of Radiology for the kind invitation and the opportunity to share our research on abdominal imaging manifestations of COVID-19. Before I start, I would like to acknowledge and thank all the healthcare workers, including radiology personnel working on the front lines during this COVID-19 crisis. So the main objective of this talk is to share with all of you what we learned about the abdominal imaging manifestation in patients with COVID-19. Coming to the outline, I would like to first start by providing a background discussing why and how our work on this topic came about, followed by Rajesh, who will be discussing the findings on the abdominal manifestations in detail. Now, COVID-19 or coronavirus disease 19 needs no introduction. Caused by severe acute respiratory coronavirus 2, this pandemic has caused global havoc and has upended all our lives in ways we could never imagine. I just want to show this dashboard created by the Centers for Systems Science and Engineering at Johns Hopkins University, which shows the number of confirmed cases, which stands at over 13 million cases worldwide as of yesterday. But in reality, I think there might be many more red dots because I am sure there are more cases than what has been confirmed. Now, this is where we are located in the map. That is the state of Massachusetts on the northeastern part of the United States. We have, as of yesterday, over 100,000 confirmed cases of COVID-19. Now, this is how the map of Massachusetts actually looks without the dark cloud of COVID-19. And here in Boston is where our hospital is located. Now, our hospital where this research was performed has been recognized by the US News and Report as the second best hospital in United States of America. But we would like to think we are the best. Our radiology department is one of the world's premier medical imaging facilities, performing nearly 1 million diagnostic exams annually. The reason I want to mention that is our hospital, which is a quaternary care center, has been one of the main hospitals in the fight against COVID-19 in the Boston area. And this chart here shows the number of cases that we have seen since early March. So if you look at the chart, around the time of mid to late April, we had when we had experienced our peak, we had nearly over 350 COVID positive inpatients in the hospital. And if you look at the numbers over the past 3 months, we've had over 1,500 COVID-19 patients treated and discharged from our hospital, including patients who succumbed to the disease, around 187. Another chart on the right shows the COVID-19 patients presenting to the ER, which almost is similar to the patients who were admitted to the hospital. Now, from this cohort of patients treated at MGH, we performed this study, which got published in Radiology in May. Now, let's go over the clinical perspective. Now, COVID-19 is an infectious disease with most common symptoms including fever, cough, myalgia, and fatigue. While the majority of cases result in mild symptoms, some progress to acute respiratory distress syndrome, followed by either multi-organ failure or septic shock. While the initial reports on this disease focused on respiratory symptoms, with increasing testing capacity and case numbers, symptoms affecting other systems were identified. Now, if you look at the gastrointestinal manifestations, some of the initial reports, including an early paper by Carrel and colleagues, reported that gastrointestinal symptoms such as diarrhea, nausea, vomiting, abdominal pain, and loss of appetite were identified in over 30% of patients. A majority of the patients in this study described the gastrointestinal symptoms to be mild. Now, the duration of gastrointestinal symptoms has been reported to be significantly shorter than the duration of the respiratory symptoms. And this study also found that a portion of their patients also presented with elevation of liver enzyme levels, indicating potential liver injury. Now, how does this happen? Now, if you look at the pathophysiology, the SARS coronavirus 2 is thought to gain access to cells via surface expression of angiotensin converting enzyme 2 or ACE2, a transmembrane protein which is distinct from the ACE, which converts the angiotensin 1 to angiotensin 2, which is a vasoconstrictor as part of the renin-angiotensin system. As you can see in this image, the virus uses this transmembrane protein and also employs the cellular serine protease, TMPRSS2, for priming and entry into the cells. Therefore, tissues with high levels of ACE2 expression are assumed to be susceptible to the direct infection. Now, ACE2 surface expression is most abundant in lung alveolar epithelial cells, enterocytes of the intestine, and vascular endothelium. The large amount of ACE2 surface expression in the gastrointestinal tract and less so in the biliary epithelium has been offered as possible explanations for GI symptoms and liver injury. In addition, studies have found that the COVID-19 virus has been identified in stool samples of a substantial portion of infected patients. So what led to our study? Around the time of mid-April, several reports, in fact, there was a deluge of reports in the radiology literature which had evaluated chest imaging findings in COVID-19, which had led to a greater understanding of the pathogenesis in the lung. Now, despite the widening recognition of gastrointestinal manifestation, there was no description of abdominal imaging findings. As the number of COVID-19 patients in our hospital was rising, we started seeing an increase in number of abdominal imaging studies performed in patients with gastrointestinal manifestations. So during our routine daily rounds, where we discuss interesting cases, we started looking at certain perplexing manifestations which had not been reported. So with that sort of background, we decided to perform a study with the sole purpose of reporting the abdominal imaging findings in patients who were admitted in our hospital. So how did we go about it? So we included all consecutive patients who were admitted at our institution over a 2-week period from late March to mid-April who had tested positive for COVID-19. We did not exclude any patients during this time period. We queried our electronic radiology database to identify all the abdominal imaging exams performed in this group of patients. And these included a range of ultrasound, CT, X-rays, as well as, I think, one MR exam which was performed. Now, all the cross-sectional imaging studies in these patients had been interpreted in the clinical setting by fellowship-trained abdominal radiologists, part of our group. Subsequently, we also reviewed the reports and images. Myself and Rajesh, we went over the images, trying to identify certain features. Now, in addition, because several of the images features we describe in our study are subjective, we use certain objective criteria to identify bowel wall thickening, fluid-filled colon, distension of the gallbladder, sludge within the gallbladder, gallbladder wall thickening, and presence or absence of fatty liver. Following the review of the imaging findings, we had other members of our group who looked at the medical records to identify the gastrointestinal symptoms at presentation, including the type of symptoms, the ICU admission rate, and the treatment algorithm which the patient received. All the surgical findings in those patients who went on to have surgery were reviewed by an experienced critical care surgeon with over 24 years of experience. And the pathological findings were verified by a gastrointestinal pathologist who had been doing gastrointestinal pathology for over 20 years. After the data was compiled, these were analyzed by us to identify what the significant findings were. With that, I want to hand over the presentation to Raj, who can now discuss what we found.
Thank you, Avinash, and thank you everyone for having me here today. As mentioned, my name is Rajesh Bhayana. I was an abdominal imaging fellow at MGH last year, and as mentioned, I'm currently staff in Canada at Toronto General Hospital. And so this is truly an international affair, and I really thank you guys for having me here today. So for my part of the talk, as Avinash alluded to, I'm going to briefly talk about our study population and then focus predominantly on our key results. But specifically speaking, the majority of my part of the talk is going to be looking at the imaging findings themselves. So we're going to look at images themselves in these patients and then discuss their importance in this population. So first, our study population. And we have this table here that outlines the descriptive statistics for our population, and it can look a little bit overwhelming at first, but we'll just take you through. I'll take you through kind of the most important parts of this this particular table. So the first column here is all of the patients that we looked at. So as Avinash nicely pointed out, we we looked at all patients who were admitted over a 2-week period, and during that 2-week period, there were 412 patients who tested positive for COVID-19 that were admitted to our institution at MGH. The second column is those of that group who went to the ICU, so a sicker group. So 136 went to the ICU. That's about 1/3 of the population. And the third column is those who were admitted but did not go to the ICU, so inpatients but not as sick or not requiring ICU admission. And the first thing that I'll draw your attention to is the age. So the average age of our population was 57 years, and you can see there was quite a broad range from 18 to over 90 years of age. And you'll also notice that the average age of those who went to the ICU or the sicker patients was higher than the non-ICU cohort. So 59 years on average versus 56 years on average, which is what we might expect. In line with some of the literature that Avinash, or preliminary literature that Avinash has nicely outlined at the start of this presentation, a high proportion of our population had GI symptoms at presentation. I'm going to use this arrow here. 34% of our entire cohort had a GI symptom at presentation, and we defined a GI symptom at presentation as one of nausea, vomiting, diarrhea, or abdominal pain at the time of presentation, and 34% is in line with what was reported in the literature prior. You'll also notice that if you look at the ICU cohort versus those who did not go to the ICU, although not statistically significant, there tended to be a lower percentage of patients who had GI symptoms at initial evaluation or at presentation in the ICU or sicker cohort than the non-ICU cohort. And that's interesting because there is now literature out there that suggests that those who have GI symptoms at presentation predominantly have a more prolonged but usually a more mild course of disease. And although not explicitly supported here, it might explain this tendency in this population. And then all these numbers at the bottom here, it can look a little bit busy, but essentially what we want to, or the main point we want to drive home here is that abdominal imaging was very common in our cohort. So 33% of our population that we looked at had at least one abdominal imaging study, whether that be a radiograph or a cross-sectional study. You'll see that 17% of our population had at least one cross-sectional study, most commonly CT and ultrasound. And you'll also see that it was more common for patients who were sicker or in the ICU to have abdominal imaging. So that was true for all abdominal imaging, radiographs, ultrasounds, and CTs. Specifically at logistic regression analysis, we found that abdominal imaging was independently associated with age. So older patients were more likely to receive abdominal imaging, as well as ICU admission. So sicker patients were much more likely to get abdominal imaging or receive abdominal imaging. And so why were these studies done? Why did these patients receive abdominal imaging? Well, the most common indication for these CT scans by far were abdominal pain and sepsis, or looking for an infectious source. And as Avinash mentioned, several of these patients have been seen to have elevated LFTs or liver enzyme abnormalities. And the majority of the right upper quadrant ultrasounds were performed for that purpose, for elevated LFTs and looking for a cause of that. Okay, so now for the more interesting part. What did we find? What were the findings that we saw on CT predominantly, as well as ultrasound? And I'm going to start with kind of one of the more important findings that we saw. And I'm not going to go through a bunch of tables. This is, I promise, the last table we'll look at. After this, it'll be all images. But we saw abnormal bowel wall thickening, or abnormal bowel wall on 31% of the CTs in our cohort. So abnormal bowel wall was a very common finding on the CT scans. Because not all patients receive CT, of course, this ended up working out to about 3.2% of the entire cohort, but 31% of the 42 CTs that were performed in the 412 patients. Of the bowel wall findings, bowel thickening and pneumatosis and portovenous gas were some of the findings we saw. So you can see that there was bowel wall thickening involving the colon and rectum, involving the small bowel, as well as pneumatosis and portovenous gas, suggestive of ischemia or infarction. As well, patients who are in the ICU, so more sick patients, were much more likely to have abnormal bowel wall as one of their findings. And as you can see, small bowel thickening and pneumatosis/portovenous gas suggestive of ischemia and infarction were actually exclusively seen in ICU patients or very sick patients rather than the other inpatients. So let's look at some of these imaging findings themselves. So this is a 57-year-old man who was admitted to our institution and went to the ICU for complications regarding his COVID-19. And so just to point out some of the imaging findings, representative imaging findings that we saw, as you can see with the thick arrows are pointing to multiple loops of small bowel that are quite thickened and abnormal. There was generalized distension of small bowel, as you can see in these images, as well as the thin arrow pointing to areas of mesenteric congestion. There's also some ascites in this particular patient. So these findings in this patient were a little bit nonspecific, but findings are suggestive of early ischemia, but at this point could be seen with other enteritis, including infectious etiologies. This is another patient, again, a male in the ICU, so a 47-year-old man in the ICU. And this patient had evidence of bowel wall thickening again, so small bowel wall thickening. There was also evidence, the thick arrow demonstrates pneumatosis or frank pneumatosis in the small bowel as well. And the asterisk in the right upper quadrant of this coronal CT demonstrates a loop of small bowel that was non-enhancing. So these are all findings, as we all know, that are in keeping with or highly suggestive of not only ischemia but bowel infarction. And in this particular patient marked by the thin arrow, you'll see that there was actually a frank gap in the bowel wall. And so this patient had actually had a perforation of his small bowel by the time that he had his CT scan. And so this patient, after having this CT, and these findings are in keeping with bowel infarction, went on to go to the operating room. And in the OR, there were a few peculiar findings that were noted. So this is an image in the OR taken by our surgeons. And As you can see, there's this peculiar yellow discoloration of bowel. So several of these loops were, very yellow in color, which is very atypical of bowel infarction. Most commonly in bowel infarction, you see kind of a dark purple or black discoloration of bowel in keeping with bowel infarction. But the surgeons at the time of surgery noted that this was quite atypical. And the areas of ischemia and infarction were also very well demarcated. This patient unfortunately passed away, very shortly after the surgery, and as a result, did not have bowel resection, and there was no pathology associated with this particular case. This is another patient. So this is another male who was in the ICU, so a 54-year-old man who was in the ICU for COVID-19. And again, you can see this thick arrow points to a loop of distal ileum, so quite a long segment of distal ileum with frank pneumatosis, thickening, and there's mesenteric congestion adjacent, as marked by the thin arrow. You can see that the pneumatosis, or the gas in the bowel wall, is quite rounded in morphology, oftentimes kind of referred to as this pneumatosis cystoides intestinalis, or kind of a rounded shape to the or cystic appearance of the pneumatosis itself. For all intents and purposes, the differential is relatively similar, and for us, pneumatosis is pneumatosis, and this is suggestive or in keeping with bowel ischemia and potential infarction as well. So this patient did also, after the CT, go directly to the OR, and in the operating room, there was no frank necrosis noted at surgery, but there was pneumatosis that was seen, and the area of ileum looked kind of fibrotic and scarred down. They ended up resecting the bowel, and when they resected the bowel and looked at it, and the pathologists looked at the pathological slides, you'll see the first thing I'll point out is that you can see a very nice correlation for the pneumatosis. If you look at the asterisks on this particular slide, the asterisks are pointing to empty spaces that were gas-filled, which is a very nice rad path correlation of the pneumatosis cystoides intestinalis, or pneumatosis that we're seeing on the CT on the left versus the micrograph on the right. And the pathologist also noted evidence of mucosal ischemia, so ischemic chronic injury was noted in the mucosa with several findings of ischemia, including villus blunting and degenerative ischemic change in the mucosa itself. But more interesting than that kind of rad path correlation is kind of the finding that was noted in the submucosa adjacent to the areas of ischemia. So the pathologist specifically made note of the fact that deep to the areas of mucosal ischemic injury, there was evidence of submucosal arterioles, or essentially small arteries in the submucosa that had small fibrin thrombi within them. And so these black arrowheads are pointing to small fibrin thrombi in the submucosal arterioles just deep to where we saw, or where the pathologist saw, the ischemic injury in the bowel wall. And so these fibrin thrombi, when they're seen on pathology in the setting of ischemia, are not always specific to a specific etiology. But given that we know that patients with COVID-19 are coagulopathic, which is very well known and widely reported in the literature now, we also have seen a lot of evidence of small vessel injury elsewhere in the body. Given kind of that picture in this COVID-19 patient and these thrombi adjacent to the ischemic injury, this is suggestive of, or at least raises the possibility that these small vessel thrombi might be causing the ischemic injury itself. So this is another patient, which we'll get to the case a little bit later, but this is a 52-year-old man who also had findings of portovenous gas on radiograph, actually. They ended up going directly to the OR after having their radiograph, so they didn't have a CT. And at surgery, they ended up having bowel necrosis, or frank small bowel necrosis. When the small bowel was resected and taken to pathology, again, there was evidence of mucosal necrosis and evidence of ischemic injury in the mucosa. But not only that, again, as indicated by the arrowheads here, there were multiple areas of submucosal arterioles with fibrin thrombi within them as well. In this particular case, the pathologist specifically noted that the fibrin thrombi were quite prominent, and the areas of necrosis were also very well demarcated in those zones. So, again, given that we know that these patients with COVID-19 are coagulopathic and susceptible to vessel injury, and this is adjacent to the areas of ischemic injury, this suggests that this might be, again, related to or potentially causing the ischemic injury that we were seeing in these patients. A very important point, I think, for radiologists to know, so us as radiologists to know, is that in 3 of the 4 patients who we saw with evidence of ischemia and or bowel ischemic injury, the initial radiographic or imaging findings were detected on either radiograph or ultrasound initially incidentally. Okay, and that's obviously important because us as radiologists are not always looking at CT, which is a little more sensitive for these findings, and we need to know, that these findings are seen in these patients and be able to pick them up. So on the left here, we have a radiograph that was performed in the COVID-19 ICU patient that I had talked about on the previous slide with prominent fibrin thrombi. And you can clearly see, as marked by the thin arrow here, that there were multiple branch-like lucencies in the right upper quadrant in keeping with portal venous gas. And this patient, after this finding, was taken directly to the OR and had those pathologic findings of ischemia as well as the fibrin thrombi that we showed on the last slide. And then on the right here, we have an ultrasound that was performed in a patient who was admitted to the ICU with COVID-19 as well. And this ultrasound was performed in the right upper quadrant specifically for elevated LFTs. And incidentally noted were these branch-like echogenic structures in the liver that were peripheral. And you can see that just deep to the areas of linear echogenicity were kind of prominent dirty shadowing deep to it. So, in keeping with portal venous gas, or at least gas within the liver, and given the peripheral nature and clinical picture, this was felt most likely to be related to portal venous gas. The patient subsequently had a CT, and the CT confirmed the portal venous gas. But not only that, an interesting finding was seen in the transverse mesocolon. So you can see the transverse colon here anteriorly. And then kind of in the transverse mesocolon, you see this gas in the vasculature of the transverse mesocolon, which is something that, we commonly see when there is either pneumatosis or bowel ischemia or infarction. And so this patient, as a result of these findings, went directly to the OR after the CT as well. There was no evidence of necrosis at the time of the surgery, but interestingly, there was patchy yellow discoloration of the transverse colon, kind of an interesting correlate to the fact that we specifically saw gas in the transverse mesocolon in this particular patient. This patient ended up having a second look laparotomy, and the transverse colon ended up looking completely normal at follow-up, and the patient did not have any bowel resection, so there was no associated pathology. Unfortunately, the patient ended up doing better after that. So why am I kind of making a point of these findings? I've kind of mentioned it before, but this really emphasizes the point that us as radiologists need to, be aware of these findings on non-CT modalities. So, the findings of portal venous gas on these modalities, as well as pneumatosis. And I think it also raises the point that because only a relatively small subset of patients with COVID-19 end up having a CT of their abdomen and pelvis, it's probably also worth noting that, given that radiograph and ultrasound are less sensitive for these findings, specifically findings of ischemia in general, it might also suggest that the incidence of kind of ischemic findings in our population may have been higher than what we were able to detect, given the relatively low number of CTs that were performed. In fact, since our study was published, there have been several reports in the literature of bowel ischemia in other patients who have COVID-19 or were kind of treated for COVID-19. So, we've looked at some of these imaging findings. We've looked at some of the surgical and pathologic findings that relate to the bowel wall abnormalities that we were seeing in these patients. But the big question here is why? So why are we seeing this spectrum of bowel wall findings in these patients? And when I say spectrum of bowel wall findings, I'm specifically referring to the fact that, although we focused on these more severe findings of ischemia, bowel infarction, etc., there were also several patients who had just mild bowel wall thickening that was nonspecific, and there was no pathology or surgery to know why that was the case. So when we're looking at what the reasons for this spectrum of findings are, although we can't really make any hard conclusions based on our study alone, there are multiple possibilities that need to be considered, and it probably depends, or likely depends, on the particular case that we are talking about. So in the more severe cases, so the findings or the cases that we presented recently, or that I presented just now with bowel necrosis, the more severe findings, based on our findings in this study, including the radiologic, surgical, and pathologic findings, suggest that small vessel thrombosis is a contributing factor. And there is, as we all know, a lot of other literature that is supportive of this idea. So we know that sick patients with COVID-19, as I've mentioned before, are coagulopathic. There are reports in the literature of complement-mediated microvascular injury. Patients have been reported to have vascular imaging findings in the chest and other areas in the body who have COVID-19 as well, as evidence of direct inflammatory effects of the SARS-CoV-2 or coronavirus on the vasculature itself. So these are all supportive of kind of a small vessel etiology of these kind of more severe findings that we're seeing. In any given case of ischemia or bowel infarction in a patient who especially is in the ICU, if we don't see an obvious large vessel thrombus, of course, we always have to consider NOMI or non-occlusive mesenteric ischemia as a possibility. ICU patients who are very sick and require circulatory support with vasopressors, etc., are obviously also at risk for bowel ischemia. And lastly, for mild cases, some of the cases where we don't have pathologic proof or kind of any surgical correlation because they didn't go to the OR, we need to consider other etiologies. And kind of, as again outlined in the introduction, direct infection is a possibility, and there is theoretical basis for that as a possibility. Specifically, this is supported by the fact that ACE2 is heavily expressed in bowel, specifically small bowel more so. But not only that, stool samples in several studies have been shown to have the SARS-CoV-2 virus or the coronavirus, as well as some intestinal mucosal biopsies have also been shown to be infected with the virus as well. So this is something that we obviously didn't look at in our particular study. We're speculating based on the literature that's out there and kind of the more mild findings that we saw. This is obviously something that requires more work. So moving on from the bowel wall findings, I'll quickly go over some of the other CT findings that we saw. In a small subset of patients, we observed solid organ infarcts in at least one of the kidney, spleen, or liver. So it was 5% of our CT scans had at least one solid organ infarct. And this, may be related to the vascular phenomenon that we've been talking about, as well as potentially other systemic factors. This is in line with some of the other literature that has or other cases that have been presented in the literature of organ infarcts in COVID-19 patients. One of the other common findings that we saw on CT was a finding of a fluid-filled colon. And so this image here shows a sigmoid colon filled with fluid rather than well-formed stool. This is obviously indicative of a patient who has diarrhea. We also saw this finding more commonly in patients who are in the ICU. Okay, and so firstly, we know that diarrhea is a common finding or common clinical finding in patients who are in the ICU in general. So seeing this finding more commonly in ICU patients was not necessarily surprising. However, we also do know that, as outlined in the introduction as well as kind of our paper, GI symptoms are pretty common at presentation in patients with COVID-19. And we know that, these GI symptoms, including diarrhea, can often be overlooked at presentation due to the presence of other symptoms. And so, although we often see fluid-filled colon as radiologists, and it's something that we often don't comment on because we see it so frequently, kind of during this pandemic and knowing that, we're going to see a lot of patients with COVID-19, this finding might draw the attention of the clinician to GI involvement in GI manifestations in these patients. I should also mention, kind of as alluded to prior, there may be prognostic value in GI involvement and GI symptoms. So this is also another reason to potentially mention this finding when you see it. The last finding that I'll talk about that we saw on CTs, of course, included lung-based findings. First of all, as we'd expect, of course, in patients with COVID-19, we saw findings of atypical infection in the lung bases in many of these patients. But in this particular case that I've put up here, the diagnosis of COVID-19 was suggested in the first place based on the abdominal CT. So this is a 53-year-old patient, a 53-year-old female who presented to their physician with abdominal pain, nausea, and vomiting. So they had no respiratory symptoms at that time. A CT scan was pursued, and in the lung bases at our institution, we noted these bilateral ground glass opacities or patchy ground glass opacities that are kind of pointed out here by the white arrows. And as a result, given the pandemic, we raised the possibility of atypical infection, including COVID-19, despite the absence of respiratory symptoms. The patient then, who at the time was not being considered for COVID-19, ended up having a test and tested positive. So, this really kind of emphasizes the importance for clinicians, as well as us as radiologists, to be attuned and kind of alert to the atypical presentations or the possible atypical presentations of COVID-19. Not only this one case, but other papers have been published in the literature. There was a series in AJR, as well as other series of neck CTs with atypical presentations that had incidentally picked up kind of findings of COVID-19 in the lungs. So something to think about, especially during this unprecedented time. Very briefly on ultrasound, the most common finding that we saw in actually the majority of the patients who had right upper quadrant ultrasound was a distended or dilated gallbladder filled with sludge, suggestive of bile stasis in the gallbladder itself. So on 54% of the right upper quadrant ultrasounds, we saw this finding. So we started seeing this quite commonly in these patients. And so a finding of a sludge-filled distended gallbladder, as we all know, is something that's pretty common in ICU patients in general. 4 of the patients who had this finding ended up having cholecystostomy tubes that ended up demonstrating no evidence of bacterial superinfection. I should also note that just under 30% of the right upper quadrant ultrasounds noted either moderate or severe fatty liver. And of course, there was the one patient that I showed earlier who had incidental note made of portovenous gas, who ended up going to surgery. So as a brief conclusion, first of all, abdominal imaging, or we found that abdominal imaging was quite common in patients with COVID-19. And not only that, but abdominal symptoms were common, or manifestations were common in these patients as well. As we know, we are still likely very early in this pandemic, and we're going to continue to likely see several patients who have COVID-19. Hopefully it's a low number, but we are likely going to see other sick patients with COVID-19 imaged. And not only that, not only chest imaging, but we're going to see abdominal imaging in these particular patients. So that means that us as radiologists, or we as radiologists, need to be aware of these findings. So today we reviewed kind of our preliminary results in the 412 patients who were admitted to our institution over 2 weeks, which included the findings that we presented here today, including bowel wall abnormalities, including the kind of more emergent finding of bowel ischemia. That, based on our pathologic and surgical findings, it was suggested that these might be related to small vessel disease or small vessel thrombosis. But related to these pathologic findings and even abdominal imaging findings in general, our study was intended to be descriptive, kind of exploratory and preliminary. So this is based on our 2-week experience, and we need to continue to look into these, and follow-up studies will ensue to better understand the manifestations in the abdomen and pelvis. So again, if you're interested in taking a deeper dive into our paper in particular in this topic, the full paper is available freely on the Radiology Journal website. As I understand,
thank you both, Rajesh and Avinash. Those are very clear presentations. We've got a lot of questions, actually. I've been trying to focus on this. I think the initial question came across, and you alluded to that in your talk, Rajesh, towards the end. Have you come across any patients who have abdominal symptoms only and have ended up being COVID-19 positive?
Yeah, so kind of as alluded to with that one particular case that we showed with patchy findings in the lung bases, that was the only one in our series. So remember, we had 412 patients who were admitted over 2 weeks. Of those, 42 had CT, and of those 42 who had CT, one of them presented with abdominal symptoms only, and based on the lung-based findings, ended up being considered for COVID-19.
Thank you. And as we move on to the next question, there were a couple of questions on the yellowish discoloration of the bowel wall and what you thought about that. Can we explain why it's yellowish and it doesn't look similar to normal bowel infarcts? And also, is this COVID specific?
Sure. So essentially, when the surgeons initially noted this yellow discoloration of bowel, they noted it in 3 of the patients. And of those 3 patients, all 3 times, different surgeons noted this to be very atypical. With that being said, I think that these are all, first of all, very sick patients in the ICU. We do know that when patients have bowel ischemia and then necrosis and then gangrenous change, the gangrenous change can often have a yellow discoloration of bowel. But given the kind of technology that we have today, we often detect ischemia and infarction relatively early in its course, so we end up seeing it in most cases outside of COVID-19 as dark purple or black and not yet gangrenous. Some of these patients might have had abdominal symptoms for several days and with comorbidities in the lungs, kind of sitting around with bowel ischemia for several days and then get imaged and finally go to the OR because we're not necessarily looking for abdominal manifestations in these patients, or we weren't at least prior to this. These things might have been missed and sitting around for a while, and then the yellow discoloration likely reflected gangrenous change. That was in 2 of the patients that had frank ischemia and infarction. However, in one of the patients who, if you guys remember the case with the transverse mesocolon gas and patchy yellow discoloration in the transverse colon seen at surgery,
That's super. Thank you very much, both of you. Very informative. On that note, we've run out of time, and I would like to bring this event to a close. I would once again like to thank both our speakers for taking the time out of their busy schedules, given the time zone differences, to be with us today. I would also like to thank our platinum sponsors, the BIR staff, and you, the delegates, for making this event a successful one. There will be a further GI virtual event organized by the BIR towards the end of the year, so please do keep an eye out for this.